Hello, Namaskar, and good day to respected viewers of Online Anesthesia. Welcome to yet another episode of Video of the Week. Myself, Dr. SUNIL DIXIT, consultant anesthesiologist. I am working as a freelancer since 31 years in the city of Chandrapur, Maharastra. It is located at the boundary of the Telangana. I have done MD Anesthesia, FCCS, PG certificate course in pain and certificate course in ECG. I am ex-director of Pulse Critical Care Center Chandrapur. I have won 2 times COPS Award in Private Practitioner Forum at ISA National Conferences. 1 time Best Poster in All India Pain Conference Hyderabad. My article is in IJA. I am a regular faculty at national and state conferences. My areas of interest is regional anesthesia. So in this week I am going to talk about how I modified available loss of resistance epidural syringe to auto detect mode with the help of rubber bands. My motto behind modification is that this modified syringe will be helpful to all the anesthetists working in the rural compromised setup. Let me share my screen here. Introduction part. Epidural placement is a safe, effective means of providing surgical anesthesia or post-operative analgesia. Mastery to epidural placement comes with practice and persistence. A thorough knowledge of anatomy is required for safe application. Being a clinician, we all know that epidural space is the potential space between periosteum lining the vertebral canal and the spinal durameter. As far as extension is concerned, superiorly it extends to foramen and magnum, where dura is fixed to the base of the skull, whereas caudally it ends at the sacral hiatus. Anteriorly, dura is closely adhered to the periosteum of the vertebral bodies, and the most anterior boundary is posterior longitudinal ligament. Posteriorly, it is more extensive and easily distensible. It is semi or half moon circular space. Anterior region is almost non-existent, whereas posterior region it can be measured. Beyond epidural space lies spinal meninges and CSF. The space can be entered at cervical, thoracic, lumbar and sacral regions, whereas in pediatric patients the caudal approach is commonly used. What are the average values of epidural space? It has been found that smaller the space, higher the pressure. So it is highest at the lumbar region, where it is 5 mm to 6 mm, where it is narrow at the cervical region, where it is found to be 1 mm to 1.5 mm, whereas upper thoracic 2.5 mm to 3 mm and lower thoracic 4 mm to 5 mm. Following the injection of radio contrast medium, when lateral X-ray is taken, it has been found to demonstrate the sawtooth pattern of the space. When MRI is taken, in MRI it is found 3 to 4 times larger at the caudal than the cephalic part of each segment. Thickness of dura. It is thinnest at the lumbar region, whereas thickest at the cervical region. It is 2 to 1.5 mm at the cervical region, whereas at lumbar it is 0.62 to 0.33 mm. Upper thoracic is 1 mm and lower thoracic is 1 mm. We all know that the epidural space is not an empty space. Rather, it is filled with areolas connective tissue, fat. More the fat, there will be longer elimination half-life of opioids. Spinal nerve roots are there with dural sleeves, but they are laterally located. Blood vessels are there. spinal arteries and venous plexus, they form Betson's plexus. Lymphatics are present which are near the dural roots. What about areolar connective tissue? They are present in significant amount ventrally, forming strong connection between dura mater and anterior longitudinal ligament in the vertebral canal. There is a band of connective tissue which is rarely visualized, which is present in the space. It is known as plica mediana dorsalis. It is present in the form of strands which connects fleval ligament to the dura. It is always, if it is present in the midline, and it divides the epidural space into right and left sides, thus it narrows the space. In some instances, it forms a complete membrane in a dorsomedial sagittal plane, and this type of connection is well developed in region of vertebral arches. It is a rare entity, but if it is present, there will be always difficulty in insertion of a needle or catheter in midline, which results in deposition of drug slightly on one or other side. It will lead to spotty or unilateral anesthesia. There will be difficulty in advancing catheter freely, and it may cause coiling of epidural catheter inside. We all know that there is a pressure in epidural space, but it is a negative pressure, and it is more at the sites of firm attachment. The communications between the epidural and the paravertebral spaces explains this phenomena of negative pressure. It reflects the abdominal pressure. It is highest at the thoracic, followed by lumbar, and followed by the sacral region. The pressure changes are more pronounced in thoracic region, whereas it progressively dissipated by the buffering of the epidural fat. Whenever cuffing will there, it will produce positive pressure within the space. What are the factors that affect the negative pressure? Deep breathing, young person, old people with ligament change, and malflexion increases the negative pressure, whereas if patient strains and patient is found to be tense, the negative pressure decreases. Out of 5 ligaments present in the vertebral bodies, ligamentum flavum is of utmost importance for the anesthesiologist. What is ligamentum flavum? These are perpendicularly aligned elastic fibers which connects the adjacent lamina. They become progressively thicker from above to downwards. During the procedure of finding the epidural space, the elastic recoil, which is transmitted to a syringe attached to an epidural needle, is more obvious in the lumbar region than in thoracic region. The veins which are present in the epidural space, they are all present in anterolateral area. They are found to be wall-less, vertebral, venous plexus of Batson. They forms a connecting link between the pelvic veins below and the cerebral veins above. These veins directly drain into azygos system of veins. Whenever there is an obstruction to venical flow, for example in pregnancy or abdominal tumors, these veins become engorged, thereby reducing the space, so less dose of anesthetic drug is required. How to reach the epidural space? It can be reached by midline or by paramedian approach. So if we want to reach the epidural space by midline approach, the structures to be penetrated are skin, subcutaneous tissues, supraspinous ligament, interspinous ligament, and ligamentum flavum. Whereas paramedian approach, supra and interspinous ligaments are skipped. How to find the epidural space by paramedian approach. It is useful at high thoracic level above T9 to T10 where spinous processes are acutely angled. How to reach there? First, we have to identify the spinous process at the desired interspace level. Now, local anesthesia, skin wheel is created 1 to 2 finger breadth lateral to the entry point. Needle is entered perpendicular to the skin until transverse process of vertebra is encountered. Needle is walked of the transverse process moving superiorly and medially about 15 degree to 13 degree angulation until needle is engaged in ligamentum flavum. We should not cross the midline. Now what about innervation? Facet joint is well innervated. Supraspinous, interspinous, they are partly innervated, so there will be less pain, and ligamentum flavum, posterior dura, lamina, vertebral bodies and spinous processes are insensitive. Now what about innervation? Facet joint is well innervated. Supraspinous, interspinous, they are partly innervated, so there will be less pain, and ligamentum flavum, posterior dura, lamina, vertebral bodies and spinous processes are insensitive. What are the contraindications of epidural anesthesia? Patient refusal, sepsis with hemodynamic instability, uncorrected hypovolemia, coagulopathy. These are absolute contraindication for epidural anesthesia, whereas elevated ICP, progressive neurological disease, example multiple sclerosis, and localized infection at injection site are found to be relative contraindication. What are the advantages of epidural anesthesia over subarachnoid block? It is a segmental block and there is always flexibility in density of block. So, if less motor block is desired, lower concentration of local anesthetic can be used. Thus, for example, in cases of walking epidural of labor analgesia, gradual onset of sympathetic block is always there. It allows time to manage associated hypotension, and the duration of anesthesia can be prolonged by bolus redosing through an indwelling epidural catheter. What are the disadvantages of epidural anesthesia? The induction of epidural anesthesia is always slower, and because of large volumes of local anesthetic, there is always risk of local anesthetic toxicity and high spinal. It is less reliable, block is found to be less dense, and block can be patchy or one-sided. What are the LOR syringes, loss of resistance syringes, which are used for the detection of the epidural space? These are used in conjunction with an epidural needle for the purpose of identifying the space. These are available in the market specifically designed to facilitate successful location of the space. The loss of resistance is based on the fact that ligamentum flavum and interspinous ligament, these are relatively dense tissue. When tip of epidural needle pierces ligamentum flavum, there is an abrupt decrease in the resistance. So, the contents of syringe enter the epidural space smoothly. When the tip of the needle enters the epidural space, firstly, air or saline is forced out, pushing the dura further from the tip of the needle. Secondly, the advancing plunger absorbs any forward force on the needle, thus allowing the needle to stop moving immediately. These two factors are found to reduce the risk of dural puncture. What are the factors that affect the incidence of dural puncture, patient positioning, patient movement, and clinical experience of the clinician. While performing epidural anesthesia or identification of the epidural space, the major problem the trainee faces is successfully advancing the epidural needle while at the same time he or she has to maintain the constant pressure on the syringe. To eliminate these problems, autodidact syringes are manufactured from various international manufacturers. Various autodidact syringes are available in the market. Out of that, Epidural syringe is available. These are LOR syringes with an internal compression spring that applies constant pressure on the plunger, but it is found to be very costly. There is a device known as epidural. It is attached to an epidural needle with the diaphragm inflated before entering the epidural space, and diaphragm deflates upon entering. We can see from the picture the diaphragm is inflated before entering the space, and as soon as the space is detected, it gets deflated. Epimetric syringes are also available, but they are very costly and they are elasticated strip which automatically pushes the plunger. Eject syringes are there. Where in eject syringes there are two locking points on the piston. After filling with saline or air, the piston is locked. Dr. Dhansura has modified autodidact syringe to inexpensive modification by using cuff of the sterile gloves. There is also reference of Dr. Naveen Malhotra, Jangra, a simple and cheap alternative to spring-loaded syringe for the identification of epidural space. These autodidact syringes has an advantage. As soon as needle enters the epidural space, the plunger automatically depresses. Thus, it provides an objective visual confirmation of loss of resistance, opposed to subjective feel required with the said LOR syringes which we are using now. According to Dubey et al., the finding an epidural space is a haptic feedback process. So, according to him, when operator inserts epidural needle, he tries to pursue which tissue layer or the needle is passing through by feeling the resistance on the needle. And we all know that the failure of epidural analgesia is usually result from failure to identify the epidural space correctly. Basically, it's a epidural needle insertion is essentially a blind procedure. I had modified available LOR syringes into autodidact syringe with the help of autoclaved rubber bands. What I had done, I had made 4 slots symmetrically opposite on the thumb rest of the plunger. So during the procedure, rubber bands has to be stretched into and are engaged on the slots of the thumb rest. To apply the balance force, the rubber bands has to be extended symmetrically on either side of the barrel. So, after reaching the interspinous ligament, which is judged by the firmness of the needle, the syringe filled with 5 ml of normal saline is attached and rubber bands are attached to the slots. Now, there is no need to push the plunger. With both hands, the needle is advanced. I again repeat it, the major problem trainee faces is successfully advancing the epidural needle while at the same time maintaining constant pressure on the syringe is a tedious job. This method solves this problem by allowing to use both hands to handle the syringe and simultaneously advancing the needle. Epidural syringes, we had to hold the spring-loaded syringe with one hand. This is not true with our technique. Here is a video of how I modified available loss of resistance epidural syringes to autodidact mode. Under aseptic precautions, 4 slots have to be made on the thumb rest of the plunger with the help of surgical blade, sterile surgical blade. The slots have to be symmetrically opposite to each other. While making the slots, you should be cautious that you shouldn't injure your fingers. So this caution should be taken. All aseptic precautions should be taken. Now after making slots, rubber bands which are autoclaved in the gauge pieces so that they should not melt. Then they are attached on the syringes, as you can see. They have to be attached like this on the syringe. Now we have to check the tensile strength of the rubber bands. It should be slightly loosened out. Now here I will be depicting lumbar epidural under all aseptic precautions after giving local anesthesia. Here I am giving 1% local anesthetic 4 ml at the L3 L4. After infiltration with the local anesthetic, as soon as interspinous ligament is reached, which is judged by the firmness of the needle, syringe is attached, filled with 5 ml of normal saline. The rubber bands are stretched and they are attached on the slots. As the slots are well symmetrical to each other, so after application of the rubber band, symmetrical force is applied on the plunger. After attaching, as the result of the syringe, not to worry because the syringe is an interspinous ligament and the dura is away from the syringe, away from the needle. Needle is in the interspinous ligament, dura is away from the needle. Now the syringe is advanced with the help of the both hands, because both hands are used, so there is a lot of control over the needle. As soon as the space is detected, we can see the saline gets sucked in. Thus this is a objective confirmation of the epidural space. Here you can see I am giving epidural anesthesia in cervical region. The patient is in sitting position. The space is selected is C7 T1. After all aseptic precaution, local infiltration, the needle is pierced and it is, as soon as the interspinous ligament is reached, the syringe is attached, rubber bands are attached to the slots and needle is advanced slowly. Thus we can see the space is detected. Anesthesiologist, we all know that the epidural procedure is more technically challenging in patients with soft dura, for example, pregnant women and with obesity. In these cases, this syringe provides clear signal that needle has been inserted into the epidural space. Believe me, the time taken to identify the epidural space is minimal. Now, small point on the media used for the detection of the space, air or saline. Air is a compressible medium and high pressure cannot be achieved when compared to non-compressible medium, that is saline. What are the disadvantages of using air? There is always possibility of causing pneumocephalus, headache or pachy block, and if at all, rare possibility of air embolism. availability of plastic syringes, the fluid has gained popularity as a medium as it eliminates most of the problems of air. What are the disadvantages of using saline? There is always dilution of local anesthetic affecting sensory blockade and confusion with CSF if at all accidental dural puncture occurs. So how to distinguish between CSF and saline? CSF is always found to be warm, whereas saline is found to be cold. Gedelef et al. Has done a study. Whenever saline is used prior to the catheter insertion, there is in saline group 2% of chances of blood in the catheter, whereas whenever air is used, there are 20% of chances of blood in the catheter. References say that saline before catheter lowers the vein coagulation from 12.9 to 6.4%. Now it has been suggested that the incidence of dural puncture might be reduced when using LOR to saline while applying constant pressure on the plunger.